Hello, everyone, and welcome to the first lecture of the Pearls Lecture Series of 2024. My name is Bilal. I'm a final year medical student at the University of Melbourne. And before we get started with our lectures today, I thought it was great if we could quickly talk about Pearls as an organization. So for many of you who are already here today, stands for POCUS for Emergency as well as Acute Care in Resource Limited Settings. In August of 2022, the inaugural Pearls course was run in Port Vila, Vanuatu, where physicians received handheld ultrasound probes to plug into their smartphones or tablets. And they undertook 3 days of ultrasound training from a visiting team of Australian physicians as well as sonographers. The director of Pearls, or the founder of Pearls, is actually in our chat today as well, Dr. Jonathan Henry. So since we started the first course, we've successfully ran 3 additional courses in Vanuatu, Papua New Guinea, as well as Tonga. And we're hoping to expand across the Pacific and other parts of the world as well. So we're very excited with what we're doing and very excited for what's coming ahead for us. So after we run these courses, we have the opportunity to allow these doctors to continue to receive feedback as well as mentorship through remote imaging, as well as lecture series like the Pearls Lecture Series, which we're on today. So for today's lecture, we'll be actually kickstarting our 2024 lecture series with Dr. Leigha Winters, who will be speaking on all things regarding POCUS for trauma patients in resource-limited settings. So Leigha, welcome. We're very excited to have you, especially given that your local time is currently 11 p.m. So again, just the life in emergency medicine, I guess.
No problem. Yeah, not even that late for me.
Before we get started with your lecture, I was hoping you could perhaps shed some light on your journey within ultrasound, specifically point of care ultrasound in emergency medicine, how you got into it, and how you've made it a part of your practice today.
Sure. Thank you so much for having me. I'm excited to be here. So my interest in ultrasound actually began during medical school. I did an away rotation in Southern California and really enjoyed ultrasound, but I had a nice dovetailing of my interests in global health and ultrasound, specifically point of care ultrasound during residency. I had worked on a few different projects throughout residency, collaborating on international projects, and they weren't quite what you would consider successful because the two partners weren't really clear from the outset of what the goals were. And then my third year of residency, I actually spent a month working in remote Uganda, in Masaka, Uganda, helping teach an ultrasound boot camp, which actually sounds like it's a very similar program to kind of what you guys have set up here with the Pearls initiative. And I just absolutely loved it because it was mutually beneficial. Everyone was very clear on the goals, and it really made a huge difference in terms of patient care and education. And it was a very sustainable project. So I've continued to work internationally kind of with that focus in mind of trying to bring point of care ultrasound, especially since we have so much amazing handheld technology that just progresses every year to remote areas of the world that don't otherwise have a lot of imaging options that can really be effective and safe and relatively cheap compared to, getting an MRI machine into remote Gambia or Uganda to make a difference for patients and for staff there. So that's how I initially kind of got involved in ultrasound.
Yeah, thanks so much for that insight, Dr. Winters. Yeah, that you made some great points, and I think we'll touch on many of those today as well. So yeah, whenever you're ready, please get started.
Sure. So, hi everyone, remotely. It's nice to meet everyone. Dr. Jonathan Henry and Bilal had gotten in touch with me, and we were kind of discussing what options for me to give a lecture on today. And we kind of landed on POCUS for trauma patients in low resource settings, as it sounds like this isn't a topic you guys have covered extensively during past lectures. So I just wanted to give a couple of caveats. Let me see if I can get this to work. I don't have any disclosures, but I just wanted to make sure that everyone's aware that this is not a fully comprehensive lecture on all things trauma and POCUS related. Every healthcare system and country is different and may use different trauma algorithms. In the United States, we use ATLS. I know there's international trauma ITLS as well. So this is you're gonna have to tailor it for your own program and hospital. It's not addressing pre-hospital trauma management. It's also not addressing using POCUS for treatment per se with like nerve blocks, because that's just a whole nother lecture, but focusing on like diagnostic use of POCUS in trauma patients in low resource settings. And then just remembering again that POCUS is really just should be used as an adjunct to your existing medical algorithm or workflow in your hospital. And as I have seen that lecturers have talked to you about in the past, POCUS is a bedside ultrasound modality that's used for yes/no questions and kind of ruling in diagnoses, but not per se fully ruling out diagnoses. So I figured we would just start with, it would be easier to do everything with cases. And I usually like to give my talks and have them be as interactive as possible, but with Zoom it's a little bit hard. So hopefully you guys can kind of read through the slides and think about what you would do before we move on to the next slide, but I'll just kind of present a few cases about different possible exams you could do related to trauma patients. So first case, you have a 34-year-old male brought in after a high-speed motorcycle collision. He was not helmeted. I work in a community hospital in Sacramento, and I have taught internationally in Africa and worked and collaborated internationally as well in South America. And I can say that every country I've ever visited has some, whether you're developed or developing country, has some amount of motor vehicle collision causing high percentage of trauma. So for this particular patient, very common to not be helmeted, very common to get into a pretty bad accident at high speeds. Vitals are, as you see, a little bit tachycardic, not hypotensive, quite, and temp is 36C. On exam, he's opening his eyes to pain, but he's confused. He's not really following commands. You notice he has like a left-sided cephalohematoma, parietal cephalohematoma, and a sluggish left pupil. He has bilateral breath sounds, but on the left side, he has ecchymosis of his chest wall and his abdomen, but his pelvis is stable, and you don't really see any obvious extremity deformities. So this is a case that we are going to assume you're working in an accident and emergency, which I believe is what you guys call it there, because that's what I have experience with in other countries. We call the emergency department, whatever you call it. But either way, you are in the emergency area and you don't have any radiology services. So X-ray, CT, or really ultrasound. So considering thinking about what POCUS exams would be most helpful for diagnosing and then potentially managing this patient at this point in time. So the exams that come to mind for me primarily would be for this patient with major head trauma, would be the EFAST, a musculoskeletal evaluation for fractures, especially like long bone fractures or clinically significant fractures, and then optic nerve sheath diameter to evaluate for increased intracranial pressure. So it is my understanding from Bilal and Dr. Henry that you guys have are all experienced with EFAST and maybe practicing with it. So I'll just try to make this pretty short, but EFAST is the extended focus assessment with sonography and trauma. So it is used kind of throughout the world at this point. Historically, our diagnostic options for trauma patients have been CT scan, DPL, diagnostic peritoneal lavage versus point of care ultrasound. And I'm sure everybody who's listening has some variety of experience with any of these options, but there's always pluses and minuses to any of them. So DPL, if it's performed by an experienced trauma attending, it can be rapid and it is bedside. So the disadvantage though is that it is obviously invasive. You're going into the intra-abdominal cavity, you're placing some fluid, you're lavaging it, and then pulling it out to look for any signs of hemorrhage or ruptured hollow viscus. However, there is a high false positive rate, and it only really evaluates the abdomen, not the thorax. The CT versus the FAST exam. So CT is highly sensitive and specific. It can definitively identify which organs are injured. And at least in the US and California, our trauma surgeons are always going to prefer the CT scan. However, Realistically, it's not always available, right? So there may not be a CT scan where you are working. It may be very far away. It could be an hour drive away. It can often be very expensive or not have availability. There may be other patients using it. And then most importantly, the patient may not be stable enough to get to CT scan. So if they're hypotensive or crashing, you can't kind of roll them over to the CT scan and take 20 minutes to get the CT done. And then also ionizing radiation is a consideration, which kind of increasingly becomes a concern throughout the course of your career. And for younger patients, the more radiation they're exposed to, the higher risk they have of cancers in the long term. So point of care ultrasound, or POCUS, as we're talking about, is rapid, it's bedside, it evaluates both the thoracic and abdominal cavities. It's non-invasive and there's no radiation. However, disadvantages is, as you are all probably aware, it only assesses is there free fluid, yes or no. It does not define what the fluid type is. So it could be ascites or it could be hemoperitoneum. It does not identify hollow organ injury, and it does not identify the exact source of an injury. So if you have free fluid in the abdomen, you don't know if it's a splenic injury or a liver laceration or something else that is ruptured. So really, again, it's very good for ruling in injury, but not for ruling out injury. And also, as with the DPL, it is very operator dependent. So the more experience you get with it, the better and faster you are at doing an EFAST exam. So that's just another reason for people to want to try to practice it as much as possible. So indications for the EFAST, blunt or penetrating trauma to the abdomen or chest, trauma in pregnancy or unexplained hypotension. Just a little bit about the accuracy of the EFAST exam for free fluid. It is very specific. It is not as sensitive. So again, it's very good for ruling in an injury, or not as good for ruling out any particular injury. And also for the EFAST to evaluate for pneumothorax, again, very specific, not as sensitive, so very good at ruling in. So if you see a pneumothorax, or no lung slide, you can be pretty comfortable saying, yes, that is a pneumothorax, but not as sensitive. You could miss something potentially. So since you all, I have been told, have experience with the EFAST, I'm not going to go in depth into this, but just talking about the 5 windows. So you have the right upper quadrant, the left upper quadrant, the suprapubic view, and then the cardiac, which usually you try to do subxiphoid to stay away from the chest if people are working on them doing CPR kind of thing. But if you can't get a good subxiphoid view, you can always do the parasternal long view on the left chest wall, left parasternal border. And then doing the lung exam on both the right and the left side is the extended version. So that's where you get your EFAST. So back to our first patient, the 34-year-old trauma patient. You astutely decide his blood pressure is getting a little bit soft and he's tachycardic, so you want to start with the FAST exam. So you start with the right upper quadrant ultrasound. You can see here the liver, the kidney, you can see the diaphragm, that hyperechoic white line at the top of the screen. And then you're kind of fanning through, you see a little bit of rib shadowing there. And then hopefully you guys all notice kind of right at the tip of the liver, there's a subtle free fluid, that anechoic fluid collection. So this is another example of why it's so important to be sure that you scan to the tip of the liver to make sure that you're not missing any free fluid. Another kind of side note, most people will start their FAST exam in the right upper quadrant because due to gravity and also with penetrating injury, often the liver is injured. So most frequently, if you're going to have a positive FAST exam, it will be in the right upper quadrant, unless you're concerned for like a ruptured ectopic pregnancy, then you more likely expect it to be in the suprapubic view. But most people for blunt trauma will start in the right upper quadrant because you're going to see the free fluid there first. So you have a positive FAST exam and you decide to do an extended FAST. So you look at the right lung and you're looking here, they've switched to the linear probe. You can see from the footprint, you're seeing the 2 ribs on the right and left side of the screen with the shadowing, the anechoic or like black underneath. And then you're seeing the little like ants on a log or shimmering of the pleura and the comet tails. So this is what nice normal lung slide looks like. So this is your right side. And then you're looking here at the left side, and you can see there's movement on the screen, but you're not seeing that shimmering of that pleural line, right? Just below the ribs, you're seeing that hyperechoic white line, but you're not seeing the shimmering movement of the pleura sliding on itself. So this is actually a good example of the absence of lung slide. The A line that's pointed out here is a reverberation artifact, which you can get both in normal lung and with pneumothorax. So you won't see B lines with a pneumothorax, but you will see A lines with a pneumothorax. So at this point, you've identified 2 different injuries on your trauma patient. And if he's still stable enough that you don't feel the need to rush him to the operating room right away, another exam that you should consider with your POCUS bedside skills would be the musculoskeletal exam for fractures, specifically like long bone or like clinically significant fractures. So fractures, you're going to want to use the linear probe. You want to look in the long axis of the bone of interest, and you want to follow the cortex. So that hyperechoic line in the bottom, I don't think you guys can't see my little cursor, unfortunately, but in the bottom image on the screen, about 1.5 centimeters deep, that is where your bone is. You can see that hyperechoic white line. And then kind of right in the middle of the screen, there's a little bump, and then surrounded by the anechoic fluid, and then it's kind of jagged, and then it is kind of straight again. So that's where the cortex is interrupted. It can be very easy to confuse joints with a fracture in specific parts of the body, usually more like the wrist and the feet, sometimes the shoulder. So it's important to know anatomy, because a joint can look like a small fracture, but fractures tend to bleed a lot because the bone is full of blood, obviously. So you tend to have this little hematoma around a fracture where you have that anechoic fluid collection, which is what you can see in the top image too, kind of anechoic and becoming hypoechoic as it coagulates. So there are your 2 fractures that we're looking at. And then here are a few more examples of fractures. The 2 images on the right of the screen, the upper and lower images, the lower image is actually the longitudinal version, and the top right image is the short axis transverse version of the same fracture, which it can be helpful if you're trying to figure out how disrupted a fracture really is, but usually you want to start in the long axis to identify the fracture. So you can see in all of these, you have the upper left image, you see that nice straight hyperechoic white line, and then all of a sudden there's a pretty big gap and some anechoic fluid there, and then you see the cortex again. Same thing at the bottom left image, at about 1 to 2 centimeters deep, you can see where that small fracture, and then the same thing on the bottom right image. It's actually a pretty big displaced fracture, right? So you can see the hyperechoic line. It's at least 1 to 2 centimeters before you see the bony cortex above it. And then in the short axis view, you can see the fragments. So the right 2 images on the screen, that's a femur, and that is a very fractured femur. So then you decide, because this patient that you are taking care of has this large left parietal septal hematoma, you're going to take the time to ultrasound that. And this is the image that you get. So you see this hyperechoic line, you see some, it jumps, it's not smooth, and then you have that anechoic fluid collection. So this is concerning for a skull fracture. Okay, so once you're concerned, once you've identified the skull fracture, or even before that, in a trauma patient who was unhelmeted and is now altered with a GCS of about 11, if you don't have access to a CT scanner, the point-of-care ultrasound looking at the optic nerve sheath diameter can be very helpful in trying to identify or rule in concerning features of increased intracranial pressure. So optic nerve sheath is not as commonly used, so I'm just going to quickly kind of go through the technique. Usually you want the patient supine at a 20-degree angle to horizontal, which is how most patients are brought in, trauma patients for resuscitation. You want to try to apply a tegaderm or other like clear sterile coating over the eye if you have any available. If not, it's okay. And then you want to do a thick layer of gel over the closed upper eyelid. The tegaderm just protects the eye from getting the gel all over. And then you use a linear probe again. You put it on the gel pillow. You don't want to press down firmly with the ultrasound. You want to press lightly because there is always a possibility in a trauma patient you could have a ruptured globe or a lens dislocation or other ocular injury, and you don't want to exacerbate that, but you do want to try to use the pillow as to kind of support that and not put extra pressure on the eye. You then adjust the probe depth until you're able to visualize the optic nerve behind the back of the retina. So usually want to see 1 to 2 centimeters behind the retina. And then you're going to measure from the posterior retina 3 millimeters deep, more proximally down the center of the optic nerve. And then from there, you take the calipers and you measure the lateral edges of the optic nerve sheath. So you get the diameter of the optic nerve sheath at that 3 millimeter mark. Anything over 5 millimeters for the diameter is concerning for increased intracranial pressure, and anything over 6 millimeters is highly concerning for increased intracranial pressure. And there have been a number of different studies and meta-analyses on this in recent years. And so usually anything above 6 now is where people will be pretty confident to say that, yes, this is very concerning for increased intracranial pressure. So here is the example of your patient. You did a lovely job getting your optic nerve sheath diameter. You can see you're using the linear probe. You have increased your depth, so it's a few centimeters behind the eye. You've identified your optic nerve, which is going to be more hypoechoic. It's going to be lighter than the surrounding tissue behind the eye because of posterior acoustic enhancement, which is one of the ultrasound artifacts. But the surrounding the tissue or the view behind the eye is going to be more white, and then the optic nerve sheath will be more like gray. And then you measure with your calipers. Number 1 there you can see is measuring from the posterior of the retina, 3 millimeters or 0.3 centimeters back. And then perpendicular to that, you measure the lateral edges of the optic nerve sheath, and that's 0.07, which is highly concerning for increased intracranial pressure. So you have astutely identified multiple issues in this major trauma victim. So with your bedside ultrasound, you have identified free fluid in the abdomen, a left-sided pneumothorax that hopefully you were able to address at the bedside, and then left parietal, well, the pneumothorax, probably not the free fluid in the abdomen, to clarify. And then the left parietal skull fracture and this enlarged optic nerve sheath diameter that's very concerning for increased intracranial pressure. The one other caveat for the optic nerve sheath diameter is, as with the FAST exam, it is not specifically telling you what the injury is that's increasing the intracranial pressure. So it's not specifying if it's an intraventricular bleed or an intraparenchymal bleed or brain herniation or just brain swelling. There's no specification of what that injury is. It's just saying that it is something is going on within the brain cavity that is increasing the intracranial pressure. So our second case is a 17-year-old male who was running in a race when he tripped and fell. He doesn't believe that he hit his head. He kind of limps in and he's complaining of right shoulder pain, and he can't just quite walk normally on his right foot. So his vitals are stable. On your exam, he doesn't have any obvious head trauma. He doesn't have any chest wall tenderness. He has this obvious deformity of his right shoulder. His right foot, his pulses are intact. He doesn't have any ecchymosis, but he has some posterior swelling posterior to his heel, to his calcaneus. He has a small bulge in his right calf. So presuming that you are in a department that does not have access to radiology, what would be the exams that you would consider in this patient? So the exams that I would consider, you can always think about, does this patient need an EFAS exam? Are you worried this is actually more of a major trauma than the history that you've been provided? From what he's saying, this sounds like a pretty minor trauma and otherwise doesn't have any like super red flag symptoms, but that's always a consideration. And then you also, for this patient in particular, he would really benefit from some musculoskeletal exams, POCUS exams. So we already talked about fractures. If you look, this is your patient. This is what his shoulder looks like when you talk about a deformity. And as you probably all would expect, this 17-year-old has a shoulder dislocation. But given that he fell, you can't really be sure, is it just dislocated? Is it also fractured? And if he's neurovascularly intact, you don't have to rush to reduce him, right? But you can try to do a point of care ultrasound to look for a fracture in the shoulder. The one issue with that is the anatomy in the shoulder can get a little bit complicated. So following the bony cortex of the humerus all the way up, you may not be able to definitively identify all potential fractures, but it is something you can consider doing for this patient. The other complaint that he had was his foot, right? So again, can be difficult to identify fractures with POCUS, but POCUS is very good at identifying tendon injuries. So from the story that he's provided, I would be concerned about an Achilles tendon rupture or partial rupture. So using the linear probe, you want to look along the long axis of the tendon and you want to follow it all the way to the insertion of the bone. You want to ask the patient to move there at that joint. And then you're really looking for any disruption in the tendon. So the tendon in these videos, the upper video on the upper side is the normal looking tendon. So you can see about is like between 1/2 and 1 centimeter deep. You can see that tendon. It looks like, some people say it looks like spaghetti noodles or strands of hair or thin wire all running together. So they kind of like run in a long stream together, and they look well approximated. They're nice and smooth all the way across the screen. There's not little bits of black or anechoic fluid in the middle of them. That is a healthy tendon. And then below on the bottom right side of the screen of that upper image, you can see the bone. So that's the calcaneus as it the Achilles tendon inserts onto the calcaneus. So you can see this is the insertion site and it looks healthy. The lower image is the concerning image. So you don't see those strands of hair or spaghetti of the tendon as well, because there's anechoic fluid in and around the tendon. Also, when you look at the bony insertion, there looks to be some anechoic fluid, some black area, and that can happen just like when a bone is broken. When a tendon ruptures or pulls off of its insertion point, the bone bleeds a good amount. So you have a small hematoma there. The other thing that can be very helpful if you're not sure, is this normal, is this abnormal, is to compare it to the healthy contralateral side. So looking at both his right and left Achilles tendon and deciding, do they look the same or does one look slightly different than the other? And then just kind of a side note is the anisotropy, which is an ultrasound artifact that when you are looking at a tendon or a nerve and sometimes a muscle, all the fibers are running together, but the ultrasound beam is bouncing some of the waves back to the probe and some away from the probe, depending on the angle of the probe. And so some parts of the tendon or nerve or muscle may look anechoic and some parts may look hyperechoic, and it changes as you fan kind of back and forth. So that's very common with tendons and nerves and sometimes muscles. So Achilles tendon ruptures, usually this is an acute injury superimposed over a period of overuse, often in gymnasts or sometimes runners. You can see on exam, they'll have a positive Thompson test, and sometimes you can palpate a defect. But with ultrasound, you can often see an anechoic gap in the longitudinal view. So here's an example of an Achilles tendon rupture. You can have partial or complete rupture. For us in the United States, complete rupture is usually surgical, although they have been moving away from that more and more. But partial ruptures aren't usually conservatively managed, so it is very helpful to use it at the time of that you're evaluating the patient to identify, is this potentially a complete rupture? Is this a partial rupture? And this you will often see, if it's a complete rupture, you'll see a lot of anechoic fluid. You won't see those spaghetti or hair inserting all the way onto the bone usually. So for your second patient, you've identified that he has a right shoulder dislocation with a possible fracture, and then probably has an Achilles tendon rupture. It may be partial versus complete. And then your final patient of the day is a 44-year-old male who comes to the A&E with a known foreign body in his hand. He said 2 or 3 days ago he was doing some woodworking. He got this large splinter in his hand, but he just decided to come in today because it's starting to be really painful and red, and he wants to have it removed if possible. So when he presents, his heart rate is 108 and his temp is 37.8 Celsius. On his exam, he has palpable pulses. He has some swelling and erythema of the right thenar eminence, and then his first and second fingers of his right hand are swollen and erythematous, and he's having a lot of pain with passive or active flexion of his fingers. Flexion and extension of his fingers, excuse me. So if you are working in the A&E, this is another case that POCUS would potentially come in very handy, as it were, to try and help evaluate this patient. So I would think about doing, again, a musculoskeletal exam with my ultrasound, my point of care ultrasound. I would be less concerned from his story for fractured dislocations, but could potentially have tendon injuries. But most importantly, I would be concerned about trying to identify the foreign body, and also identifying potential sources of infection, like the sequelae of this trauma, so the cellulitis or a tenosynovitis. So foreign bodies, as you guys, I'm sure, are all aware, can be really difficult to visualize, even when you have CT or X-ray or other imaging modalities. If they're not radio opaque, they can be very difficult to visualize and locate. They can be uncomfortable, and then they are very high risk of infection. They're a nidus of infection, and sometimes they'll need to go, if they're left in for too long, they can require operating room management. So point of care ultrasound can be extremely helpful in identifying the location of foreign bodies, of facilitating the removal and confirming their removal. So these are a few foreign bodies. Often with the foreign bodies, if they're not radio opaque, you don't identify them by the foreign body themselves, but by an ultrasound artifact. So the left side of the screen, that image, you don't really see for sure a foreign body. You can identify it more based off of the shadowing, that artifact. So if you follow the shadow that's in the middle of the screen all the way up, about like 1 to 2 millimeters deep, you see that hyperechoic foreign body. It's maybe about half a centimeter thick, and that's how you can identify the location. It's actually pretty superficial, and about maybe like half a centimeter. The foreign body on the right of the screen, on the upper and lower screen, it's actually, again, a short axis on the upper screen and a long axis view on the lower screen. Again, you will usually identify it by the artifact. So in this case, the lower image, you're seeing the edge artifact. So you're seeing that shadowing along the edge of the foreign body. And then you are seeing some reverberation artifact within it because it's actually metallic. I don't know how much of this you guys see in the Pacific Islands, and that would be so lovely, but this is a bullet. So we see this sometimes. I have seen this working at a trauma center, or like at a level 2 trauma center. In the community, we get a lot of walk-in gunshot wounds. We get a lot of just general gunshot wounds. And sometimes you will see people are very lucky and it ricochets off of their thoracic cavity and just slides right underneath their skin. And then you just like, often the trauma surgeon will just kind of cut out a line and like pull out the bullet. But this one you can see in both the long axis on the lower view and the short axis on the upper view how superficial underneath the skin it is. This is your patient again. This was actually a real patient of mine years ago. So this is your patient and you decide to be very proactive and use your ultrasound skills to try and identify and remove the foreign body. So you're trying to figure out the size. You're looking, I often find looking for foreign bodies in the short access view can be the most helpful, because then you don't have to be just right over the top of it. You can identify its location and then rotate your probe 90 degrees to get the long access view. So the lower image is the short access view. Again, you follow the shadow kind of up. You can see it's probably 3 or 4 millimeters deep, and then about maybe half a centimeter wide on the left third of the screen, if you follow that shadow all the way up. And then you rotate your probe 90 degrees and you look in long axis view, which is the upper image, and you can see that hyperechoic white line. It goes across almost the entirety of the screen there. And then when you're looking at the depth of your image, you can see that it's about 3 centimeters deep, and it's almost as long, the foreign body is almost as long as your screen is deep. So I would guess that this foreign body is about 3 centimeters long by maybe almost half a centimeter wide. And you managed to remove it, and you are correct. It is 3 centimeters by 0.4 centimeters of a wooden foreign body. So now you've removed the foreign body, but you're still concerned with this erythema and pain with flexion and extension of his finger. So you're really worried, does he have cellulitis? Does he have flexor tendinosynovitis, which is usually, at least in the US, is an operative emergency for orthopedic surgeons. So you want to, again, use the linear probe to evaluate this. This is the hand injuries and foot injuries are great times to use a water bath. So you get a big basin, you fill it with water, and then you can put have the patient put their hand in palm up, and then you insert the probe into the water, which should be waterproof. And you don't actually have to touch the probe against their skin. Ultrasound is transmitted very well through water, so you get great views without it touching the skin. This is also particularly helpful for kids who are really squirrely and don't want you touching them in any way. Parents can put their hand in the water, you can use the ultrasound and never touch their skin, and they will tolerate that much better. So if you're looking for tendinosynovitis, you want to look in the linear, the long, and the transverse axis. And you're really looking for a significant amount of fluid around the tendon. So here are some examples of tendinosynovitis. You're seeing, again, the spaghetti or the hair or the wires, the nice long, smooth wires. You're not seeing a bunch of anechoic fluid within the tendon itself. You're seeing it all around the tendon. And that can be extremely painful with any movement of that tendon because it's infected. This for flexor tendons of the hand, they have tendon sheaths, and that is why, and so it's like a superhighway for infection. So that is why our orthopedic surgeons will usually take them to the operating room, whereas extensor tendons do not have sheaths. So they are less likely to rapidly progress, according to our orthopedic surgeons. So we're not always taken to the OR for washout, but here are some examples of short and long access. And then here is an example of an extensor tendon. This is also a nice example of somebody using a water bath. So you can see at the top of the screen, there's all that anechoic area that's about 1.5 centimeters deep. That's just the water in the water bath. So the probe is in the water about 1.5 centimeters away from the skin. And then you're still getting amazing detail because the probe is transmitting all those ultrasound beams through the water. So you're seeing the extensor tendon, you're seeing that anechoic fluid around the extensor tendon. And then this is your patient your third patient here that you decide to ultrasound. Again, using a water bath, as you can see, you have that anechoic fluid at the top right of the screen. The hand is not very deep in the water, but you can still see there's, it's kind of a difficult view, but you can see there's cobblestoning, there's some fluid in the superficial tissue, but you're not seeing a significant amount of anechoic fluid surrounding the flexor tendon. So it's not definitively tendinosynovitis, but it is very concerning for a hand cellulitis, which also can be pretty serious. So you summarize that with this patient, you have identified, removed, and confirmed removal of this wooden foreign body. And then you have identified this patient has an infection, most likely cellulitis, could progress to flexor tendinosynovitis. So after the 3 cases, you have, we've kind of gone over a few different POCUS exams you can do for major and minor trauma patients. Major trauma patients, the ones that we will often use are the EFAS exam, the optic nerve sheath diameter, and then the musculoskeletal exam. And then for more minor traumas, again, different types of musculoskeletal ultrasound, but also soft tissue for foreign body and potentially and/or infection.